Hello, everyone. My name is Adam Creel. I am partnered with Kayla Guillory, and we are actually going to be talking about an article today for Journal Club. Just to give you the official title of it, the title of our article is Amiodarone versus Lidocaine and Placebo for Preventing Ventricular Fibrillation After Aortic Cross-Clamping. So it's a mouthful. So we'll make sure to go through and talk about this so that you really know what it's getting at there. So I just want to start out with the background of it. So basically, anyone undergoing cardiac surgery, they typically have an issue of ventricular fibrillation happening after the aorta cross clamp is removed. And so to prevent fibrillation or to defibril, they usually use shock, basically. So they use the paddles to shock them back to getting into a normal heart rate. So what happens with this, though, that they've noticed is that it can actually cause damage to the heart, to the myocardium, and the functions of the heart. And some of these damages can be permanent. So they just want to try to figure out some way that they can actually do a defibrillation without causing any type of permanent damage to somebody's heart and the function of the heart. So what they looked at is like lidocaine is an antiarrhythmic drug that's usually used. It prevents sodium from permeating the membrane. And so this prevents depolarization and the conduction of the heart, which is, basically like a fast heart rate conduction. It prevents it from being able to do that. Another one is amiodarone, and that's going to be the main treatment drug that we talk about in this particular article. Amiodarone basically antagonizes alpha and beta adrenergic receptors, blocks sodium, calcium, and potassium channels, and it actually prolongs the action potential in the refractory period in the myocardial tissue and AV conduction and sinus node function. So all that just basically says that it's trying to slow the heart back down from tachycardia, from fibrillation. So amiodarone in some studies we're going to look at, it's shown superiority compared to lidocaine in preventing fibrillation after the aortic clamp is removed. And so we want to just kind of go through some of these things and talk about some of the information in the study that either proves that or disproves that based off of the results. So two studies that we came across that had significant results. There was one in 2009. Ayub and colleagues actually did a randomized trial with 120 patients that were undergoing a CABG, that's coronary artery bypass grafting. It's common cardiac surgery. And in this case, they used three treatments. And it's the same three treatments that our study that we're going to talk about actually uses: amiodarone, lidocaine, and placebo. So what they were doing was trying to investigate whether any of these treatments would decrease the incidence of ventricular fibrillation after the clamp is removed from the aorta. In this particular study, the results showed that amiodarone actually, when used, allowed a higher incidence of ventricular fibrillation rather than decreasing the incidence of it, as compared to lidocaine. And placebo also had a higher incidence of ventricular fibrillation compared to lidocaine as well. They did report that there was lower energy needed to actually stop the ventricular fibrillation in amiodarone compared to placebo and lidocaine. So in this case, amiodarone did do a better job of requiring less energy to stop the fibrillation. The second trial, 2010, is Samantare. I just want to make sure I'm pronouncing that correctly. Samantare and colleagues. Now, they did a randomized trial with 34 patients, so a smaller population. And they were also undergoing the same surgery, which is the CABG, coronary artery bypass grafting. And in this case, they used either amiodarone or a placebo to try to prevent an incidence of ventricular fibrillation after the clamp was removed from the aorta. Now, their results actually showed that amiodarone significantly decreased the incidence of fibrillation after that clamp was removed compared to placebo. And the percent that it showed results, it was 18% as opposed to 65% for the placebo. So a way lower incidence in the amiodarone, 18% compared to placebo, 65% occurrence. So the reason why this study was conducted was they just, as we talked about kind of in the background, they just wanted to see if there's any pharmacological guidance that can be provided as far as what we can use during cardiac surgery to help prevent fibrillation in patients that are undergoing these surgeries, and just something that will not cause any harm to the myocardium that could be permanent or otherwise. Now, coming on down here, just the authors, I won't really go over them in detail, just if you'll note, if you're looking at our handout there, that there are several anesthesiologists registered on there. There is a statistician and informatics specialist on there as well, just to kind of keep track of all data. The study itself was actually done at the Mayo Clinic in Minnesota, and it was funded by the Mayo Clinic's Departments of Anesthesiology and Cardiovascular Surgery. Now, the trial design, just if we can put it down into a concise statement, it was a randomized, double-blinded, both patients and healthcare providers blinded, placebo-controlled, did include a placebo on there, and it had 3 arms in the study. So 3 arms: amiodarone, lidocaine, and placebo. Now, looking at the primary and secondary outcomes, incidence of ventricular fibrillation after removing the aortic cross clamp, and then the number of defibrillations or shocks required to cause the ventricular fibrillation to cease. Secondary outcome, relationship between, and this was actually unexpected, this is something they came across, but obviously secondary outcome, but relationship between a left ventricular mass increase and the incidence of ventricular fibrillation after the clamp was removed. So what they noticed is that the more hypertrophy or increased mass of the left ventricle, then the higher, it's basically like a predictor of higher incidence of ventricular fibrillation after the clamp is removed. So that's what they found. Inclusion criteria: ages 18 and older, anybody undergoing an elective cardiac procedure, and it was going to be expected to use cross-clamping during that procedure. Women of childbearing age that agreed to birth control for at least 5 months after the procedure. Now, exclusion criteria: anybody who had an allergy to amiodarone, organ dysfunction history from using amiodarone previously, and anybody who expected to have basically, like, if they required any type of hypothermia treatment during the bypass, that was also one of the things that they used. If it was going to be expected that they would need more than the usual amount of hypothermia treatment during the bypass, they were excluded as well. So coming on down, the intervention and experimental design section. So basically, let's just go through the experiment, what they did. So individuals, they enrolled and gave their consent. They were randomized into 3 different groups. So group A was amiodarone, A for amiodarone, group L for lidocaine, saline group, which was the placebo group, group P. Now, what they did was each drug preparation used 12 milliliters of solution. See, it was done by research pharmacists who put those together. The content of the syringes, however, were actually unknown to the surgeons, anesthesiologists, and the cardiopulmonary bypass perfusionists. So that just means the blinded part. So they were blinded as to the treatments that were going to be received by the patients in the room. So the maintenance of anesthesia, that was completely under the judgment of the anesthesiologist. The administration of the 3 different treatment drugs that we're going to be testing, including the placebo, was going to be given 3 minutes before the expected time of the cross clamp removal. And so the surgeon would notify when to do that. Let's see, patients in group A, they actually received 300 milligrams of amiodarone. Patients in group L, the lidocaine group, received 1.5 milligrams per kilogram of lidocaine. And then group P, placebo group, just received a saline solution for whatever amount was used in that case. Now, once the clamp was removed, if fibrillation occurred in the patients, they would go ahead and shock them up to 3 times using 10 joules of energy in those paddles that they shocked them with. If it was unsuccessful after 3 attempts, then a second dose of the treatment drug, whichever one group they were in, they would receive a second dose of that. Now, in the amiodarone group, they halved it. So it wasn't 300 this time, it was 150 milligrams this time. Groups for the lidocaine and placebo received the same amounts. If defibrillation continued past that, then what they would do is they would do 3 more shocks. 1 shock at 10 joules of energy, second shock at 20 joules of energy, and then a third shock at 30 joules of energy. In the operation room, what they did was they gave a sealed opaque envelope which contained the treatments that the patients were on, to the healthcare personnel. Now, the healthcare personnel could not open these envelopes until they had done the treatment, then the defibrillation, and then a second round of treatment, and then a second defibrillation attempt, and it didn't work. So at this time, they would open up the envelope and see which treatment that particular patient was receiving. And based on that treatment, they would then go ahead, under the surgeon and anesthesiologist's direction, provide further therapy to try to solve the fibrillation issue. Now, just going over the outcome measures and how they were assessed. Primary and secondary outcomes were analyzed with intention to treat, which basically just means they were analyzed according to whatever group they were originally assigned to, regardless of the treatment they were receiving. Continuous variables use the Kruskal-Wallis test, and then categorical characteristics, your nominal and ordinal characteristics and variables, were compared between groups using a chi-square test, which basically looks at relationship between categorical variables, or they use a Fisher exact test in that case. Statistical analysis. The sample size was determined based on the available literature that we had. Expected 70% of ventricular fibrillation incidents after the removal of the clamp. So a chi-square test with 80% power and an alpha of 0.0167, so right around where we want to have strong evidence indication with the number there. Estimated 113 patients were needed for each group in order to show a 30% reduction in the incidences of fibrillation with amiodarone. So to account for any dropouts, they just went ahead and did 120 patients per group. So they estimated 120 minus 113, 7. So average loss of 7 patients per group during the course of the trial. And these 120 patients were enrolled in each group. So your total study population was 360 patients. Now, for the rest of the article and the information here in this presentation, I'm going to pass it over to Kayla so she can start at results and she'll close us out. Thank you.
All right, so good evening. So for the part that I'm going to pick up from where Adam left off is the results of this study. So to begin, they enrolled 360 patients into the trial, but 18 of them got excluded. So this left a total study population of 342 patients, and 115 patients were in group A and in group L, and only 112 patients were in group P. They did note that patients in group A were more likely to have hypertension than groups L and P, and patients in group P were more likely to be taking a statin medication than groups L and A. So moving on to their results, they report that 57.3% of their patients experienced ventricular fibrillation, and so this was a little over half of their total study population. The only univariant predictor of ventricular fibrillation was from the type of operation that the patient was undergoing. So septal myectomy had a higher incidence of ventricular fib than coronary artery bypass grafting. And they were at this table, you can see the results and then the stats that they applied to it. So right here, myectomy versus coronary artery bypass grafting with the odds ratio of 5.09. So this was greater than 1. So that tells us that myectomy individuals were more likely to experience ventricular fib than coronary artery bypass, and the p-value was 0.001. And I believe that they set alpha at 0.0167, so that was, P was definitely less than alpha. So moving along and trying to keep on time here, They applied univariate predictors into a multivariate model and found that septal myectomy and valve surgery were positive predictors of ventricular fibrillation incidence. Also, that amiodarone used before operation was protective against ventricular fibrillation. So for the primary outcome measure, there was no significant difference found between the three groups in their ability to decrease the incidence of ventricular fibrillation after removal of the aortic cross clamp. The other primary outcome, which was the number of shocks required to seize ventricular fib, they applied this in a univariate and multivariate predictor model, but in the multivariate model, they found a significant decrease in the number of shocks required to terminate ventricular fib in the amiodarone group versus placebo. So for one of their primary outcomes out of the two, they found significance in their results. They also report that although the left ventricular mass was not included in the multivariate model, they did observe that an increase in left ventricular mass was predictive of ventricular fibrillation occurrence after aortic cross clamp removal. And they also found that an increase in mass would require more shocks to defibrillate. So I'm kind of going off of the template that we filled out here. And so the next section is adverse events. And they did not report any adverse events that occurred within their study. So that was good, but they did use a higher dose of amiodarone compared to previous studies. And they suggest that based on their results that this higher dose was still not enough to achieve the therapeutic levels in the myocardium. And so the next section is Arthur's conclusions. And let's see if I can do this. So that's the section right here. So the Arthur's conclusions, they point out several differences between their trial and other trials mentioned throughout the paper. I think Adam should have touched on the two major trials presented in this study. So compared to those trials, they included a variety of surgical procedures. They did a different dose of both lidocaine and amiodarone. They also state their reason for using this higher dose. They believe that amiodarone's large volume of distribution would have been adequate to sustain the hemodilution from the CBP reservoir. But this was not the case, and they suggest that for future trials to use a higher dose in order to achieve those therapeutic levels. They also objectively noticed that there was no significant differences between the three treatment groups in decreasing the incidence of ventricular fibrillation, but they did find amiodarone decrease the shocks needed to seize ventricular fibrillation. They explained that the number of patients preoperatively taking amiodarone had fewer incidents of ventricular fibrillation, but these results should be cautious because of the low population size, which was only 14 individuals. And they did do a subgroup analysis, but they did not include that in their data. But in that analysis, they found that an increase in left ventricular mass was likely associated with ventricular fibrillation development. With regards to their limitations, they included a whole separate section of that for, I guess, just to easily point out. But in their limitations, they acknowledge that despite their enrollment of a heterogeneous population, they only included patients who had normal left ventricular ejection fraction. So their results may not be able to be applied to patients with abnormal ejection fraction. Lastly, they explained it would be beneficial for future trials to use a population representing general operations that are performed more often. All right, so moving along to the last section, which is professional opinion and reflection. So for the most part, regarding the weaknesses of the trial, the authors acknowledged their major issues. The trial looked at a smaller population with mostly specialized operations being performed, as I just mentioned. They admitted to looking at other trials in which amiodarone was shown to be favorable. But in their trial, amiodarone did not prove to be effective in decreasing ventricular fibrillation incidence when compared to lidocaine or placebo. And I'm going to try to point out some of the flaws maybe that I found. I don't know if they're flaws, but these were confusing as I was reading this paper. So this, in their materials and methods, they explain how patients were randomized. So if you look at this sentence right here, it says, before operation, subjects were randomized in a 1-to-1 fashion to receive amiodarone, lidocaine hydrochloride, or saline before aortic cross-clamp removal. And so the beginning of the sentence and the end of the sentence, they have their timelines conflict, to my understanding. So if the patients were randomized before operation, this would give strength to their study because there's no way of knowing if that patient was going to encounter ventricular fibrillation after removing the cross clamp or not. And so there's less bias able to be introduced into the trial. And so at the last part it says before aortic cross clamp removal. So if they randomized them before the removal of the clamp, this means that the patient was in the operation room undergoing their surgery for however long that surgery is, probably like an hour or more. So all the teams inside of there are monitoring the patient's vitals, just everything. And so I feel like that could decrease the strength of this trial and introduce bias. So that was just something I noticed. I also noticed that in table 1 in the patient demographics, the authors did not mention this anywhere in their paper. I read it like 5 times and I did not come across this, but maybe because it wasn't significant enough in numbers in this part, but maybe it could have a downstream effect with their stats. So right here it says history of dysrhythmias, and they list the different types, and one of them is ventricular. And so this whole study was looking at the ventricles of the heart, right? And so if you look at their numbers, they had 3 patients included in the control group who had histories of ventricular dysrhythmias. They had 3 in the lidocaine, and they had none in the amiodarone. I don't know what that means, but I feel like that could have skewed their results some kind of way. And next, weakness that the study had was it did not meet power in the placebo patient group. So right here, they only had 112 patients enrolled in this group. And in the beginning, maybe Adam touched on this, but they explain how they got to their total population size number. And they set power at 80, and that gave them 113 patients in each group in order to show their 30% reduction, but the placebo group did not reach that power. So that was something I noticed. Let's see. So that was some of the downfalls or reflections. So moving on to their strengths of the study, they did use various operations and provided 3 separate treatments for each operation. They also did a randomized double-blind control study, and as we know, that's one of the best types of studies you can do. The authors do acknowledge that an unexpected secondary outcome of an increase in left ventricular mass could be used as a major predictor of ventricular fibrillation incidence, and so this moving forward can be applied in future research. Additionally, they used univariate and multivariate analysis for ventricular fibrillation incidence. The authors suggested that unless future testing is done with a different dose of amiodarone and would be shown to be effective, there's no reason to consider it over other drugs during cardiac procedures. So going forward, it might be necessary to research different drugs to see if they can be administered at safe dosage levels and achieve the desired outcome of decreasing ventricular fib incidence and the need for defibrillating shocks. That was a mouthful. All right, well, yep, that is all we have. Thank you for listening.